Welcome to this an occasional series from the American Journal of Hypertension on conversations with special issues and compendiums published in the American Journal of Hypertension. I'm Swapnil Hiremath. I'm a nephrologist and a social media editor at the American Journal of Hypertension. The other social media editor for the American Journal of Hypertension is Brandy Wen, who couldn't be with us today, but will join us for future conversations. And I'd like to introduce the other two attendees in this panelists in this conversation. Paul.
Hi, good morning. I'm Paul Muntner. I am a professor of epidemiology at the University of Alabama at Birmingham and an associate editor at the American Journal of Hypertension.
And Fleetwood.
Hi, morning. I'm Fleetwood Loustalot. I'm an epidemiologist, a team lead with the Division for Heart Disease and Stroke Prevention at CDC.
So this conversation is about the compendium released in the March 2021 issue or 2022 issue of the American Journal of Hypertension. Paul, do you want to mention what the compendium is about and how it came about?
Yes, thank you. So as you mentioned, the American Journal of Hypertension has published a compendium in the March 2022 issue of on the Surgeon General's call to action to control hypertension. And this compendium consists of a series of articles that were written to provide information for clinicians and researchers with the goal of facilitating the improvement of blood pressure control. The journal decided to focus on the Surgeon General's report because it's such an important landmark call to action, and the American Journal of Hypertension is committed to improving public health through the prevention and treatment of hypertension. I guess, let me provide a little bit of background on what is in the, let me provide a little bit of background about what is covered in the compendium. We have an editorial from Resolve to Save Lives on the role government agencies and employers can play and how they can facilitate blood pressure control through regulatory authority and workplace programs. We have an article on health equity, clearly an important issue that has been receiving a lot of attention lately. And this review goes through the well-known disparities in blood pressure control among US adults and discusses the social and economic factors that are really the root causes of health inequities and blood pressure control. There's a group of academic investigators paired with the American Medical Association investigators that reviews the high cost to the US healthcare system of hypertension and uncontrolled blood pressure. And they also review data on interventions and the cost effectiveness of interventions to improve blood pressure control. We're very fortunate to have the report from a 2-day workshop from the National Heart, Lung, and Blood Institute and Centers for Disease Control and Prevention on hypertension control. So this workshop was held in October 2020, around the time of the Surgeon General's call to action, and really brought together experts to identify where we are with respect to hypertension control and to discuss what interventions may be effective. Then finally, we have a report from the Centers for Disease Control and Prevention that discusses self-measured blood pressure monitoring, really a potentially effective approach to improve blood pressure control, and something that we at the journal think is an important area for future research, but also for clinical implication. And so with that, it's an exciting report, compendium that covers a lot of different areas.
So from your point of view, Fleetwood, have there been previous such calls to actions from the U.S. Surgeon General? I'm a hypertension nerd, so I think it's really important. But what made the U.S. Surgeon General decide to issue this call to action now?
Yeah, thanks. It was a really exciting time for us. So the Surgeon Generals frequently have priorities that they carry throughout their tenure. And the prior Surgeon General, Jerome Adams, had a specific interest in cardiovascular disease prevention, and in particular hypertension control. And so it was a great opportunity for us to partner with him and to provide the subject matter expertise from the Division for Heart Disease and Stroke Prevention to really fill out what this would look like. What would a call to action for hypertension control look like? And so we formed a team together within the division that included those from epidemiology and surveillance, from evaluation and translation, from program, from other areas of science and policy. And for a extended period of time, reviewed the literature, scanned best practices, and came together to derive a call to action that had specific goals and strategies that we carried forward within the call to action to help to prioritize hypertension control. We realized that there is a lot of evidence already available. There's a lot of things that work already to control blood pressure. And so we were able to pull those together. And the three goals and strategy, or the three goals, were to make hypertension control a national priority, to ensure that the places where people live, learn, work, and play support hypertension control. And then the third was to optimize patient care for hypertension. So each of the three goals then had strategies underpinning those, and it really overall led to a roadmap for hypertension control.
That's fascinating, and you're absolutely right. You mentioned that we know the evidence is out there, right? It's not about generating new knowledge or doing more research to find out what we should do. In fact, when I tell people I take care of hypertension, as a nephrologist or cardiologist, they feel it's very unglamorous. There are so many other exciting things. Blood pressure, we know how to treat it, right? Eat less salt, take the pills, and you're done. But for some reason, there is this knowledge to implementation gap, right? We know what to do, but somehow we don't do it. And a bunch of the articles in the compendium, of course, talk about that specifically. But is there any particular thing, Paul, that you would want to highlight that would address this kind of implementation gap? There's talk about home blood pressure monitoring, for example, self-measured blood pressure monitoring. Or the change in lifestyle. These things are things we talk about but don't happen. What can we do to make change happen?
Right, you raise a great point. I think that each article brings a perspective that lends itself to things that we can do. When I say we, I mean clinicians, researchers, people involved with the health system, with government, but also individual patients. And this is an issue that can be tackled from all directions. You mentioned self-measured blood pressure, and that really, I think, is a great example where the government can, make self-measured blood pressure monitoring reimbursable, like they've recently done. Health systems can provide home blood pressure monitors to their patients for reduced or no costs, as well as provide instructions. Systems can be set up for the transfer of data from the patient to the provider. So it really involves all aspects of healthcare. And so I think that's just one example, but there are many others where we know what to do. And now it's, the translation phase, which I think the Surgeon General lays out, makes a really good point for. Let's take that next step.
Thank you. And the thing that you mentioned, Fleetwood, about taking care towards the patients, right, in the community, could you expand on that? Like, what did the Surgeon General's call to action or your work group anticipate or think about when they were talking about this.
Hmm. Yeah, a question that I frequently received when the Surgeon General's call to action came out was, what's new, what's unique, what's novel about this? Because hypertension control has been prioritized nationally for decades. It really has. It's been in Healthy People and other national initiatives for a long time. We're unfortunately seeing a stagnation of control. We're not seeing the gains like we had before. And so we struggled with that a bit when we were developing the call to action, because so much was available right there. We've seen so many of these systems-based improvements that have come from the Kaiser Permanentes and others, that system improvements work. Using standardized treatment protocols, team-based care, these things work even in diverse communities. So the extension to that for the call to action was a focus on sector guides. And so we have a primary document that's the call to action, and we also wanted to help to translate that. So not just to create a document that used to sit on the shelf and collect dust, and now would maybe sit in somebody's file box on a computer. But the sector guides were actually things that people can take with them. The Surgeon General in conversations with us said, I want to be able to take a one-pager to different audiences and hand that to them to help them make a difference in hypertension control. And so these sector guides or partner guides focused on a number of different groups. They may be individuals, they may have been state and local government, healthcare system, policymakers, providers, and they included specific activities within those that could be interventions that would make a difference in their particular environment, and also had selected resources included as well to help people implement those. And so we spent a lot of time on that translation material to try to help people not only know and appreciate the evidence, but also make a difference within each of their different areas that they're working in. And those are archived on our website at CDC, cdc.gov/blood pressure. You can navigate to the call to action section, and within that, the partner guides are easily available, downloadable PDFs that you could take with you. Maybe you're a decision maker, maybe you're collaborating with somebody in a local community. You could print off that material and take it with you to the meeting, and maybe it will guide some activities, interventions, or even prioritize some of those as well in your collaboration.
Yeah, so the table in one of the papers in the compendium, there is a coverage of, for example, home blood pressure monitoring, and it varies so much from state to state. In some places, it's easy to get coverage, and some places have absolutely no support. And yes, it's federal, and states have their own rights. The healthcare systems have their own way of doing things. How does the U.S. Surgeon General fit with all these, different pieces of the healthcare? Is the call to action something that can push people to move in a certain directions, or is it like a resource that helps? Pardon my ignorance. I'm just asking because I don't know. But is it like resources that people can use? But is it something that policymakers can say, hey, clinicians can use and go back to their administrators saying, hey, this is what the U.S. Surgeon General is telling us to do. So let's do this. How should we think about this as clinicians?
Yeah, it really is a stake in the ground, a landmark publication that people can look back to, can reference, and appreciate that this is a priority nationally. It really folds into our main goal of making hypertension control a national priority. We're competing with a lot of things, right? There's a lot going on right now with a global pandemic, economic crises, fight for social justice, a lot of things that are going on. And so how do we continue to make hypertension control? As you said, many times it's not very interesting, even though it's a high burden condition with low cost interventions that are readily available, and yet we're not seeing the gains that we want. And so I even like Dr. Mayfield, with Dr. Frieden in the Resolve to Save Lives publication in the compendium, one of their initial lines, I think it may be on the closing of the introduction, they said it was a comprehensive approach, a nationally driven, whole of government, whole of community approach with a specific focus on financial incentives is needed for big change in hypertension control. And to me, that really struck. That was what really we were hoping to do with the call to action, is a bit of a call to attention for this activity and to provide those resources that are well recognized across different systems to make a difference. And we are seeing positive things even from a reimbursement standpoint, as self-measured blood pressure has been talked about several times. You know, what is the incentive for people to continue to implement self-measured blood pressure in their practices? We know it's good. We know it helps with patient engagement to make them part of the team. We know it works from reviews that have been done. We know it needs a feedback loop, so the blood pressure needs to be checked in the home or in the community, and that information transferred back to the provider to help engage care. How do we do that? How do we incentivize that? And there have been movements for reimbursement for self-measured blood pressure assessment and checking, which is a positive thing as well. So not just having a clinic visit being reimbursed, but also the teaching for self-measured blood pressure and engagement in those, the numbers and the modifications that can be made from there. So we need financial incentives to be able to help to support some of these interventions that are occurring. That could even be extended out to community health workers as well, which we know work, an extension of the clinical practice into the community to help to tailor interventions to individuals. So there's lots of areas that we know work, but many times there are gaps in reimbursement or gaps in the system where the evidence is there, the intervention is there, but the opportunity for that may be limited because of the reimbursement and the priority within these health systems.
Absolutely. The aspect about financial incentives, just like knowledge, right? We have the evidence. We also have the evidence that many of the things we do in hypertension are so cost effective, right? They're probably even cost saving. And despite that, some of these changes have not happened. There is again, in the compendium, there is a review which covers the cost effectiveness of different strategies. Going from changes in lifestyle as well as self-measured blood pressure. Paul, did you have anything to add on this topic?
Yeah, I was going to refer to the article by Taju and colleagues in the issue where they go through not just cost effectiveness, but cost saving. And so I think it's worthwhile for payers to look at that article and see that, these are approaches that are not going to be costing the health system money, but saving the health system money. They're gonna, and that's, obviously just the added benefit beyond the real purpose, which is to improve patient care, quality of life, and outcomes. And so the article really does go through the gamut from prevention to treatment and the cost savings of different approaches. And given the heavy burden hypertension places on our healthcare system, it's something that should be really a no-brainer.
Absolutely. So we have covered different facets of the articles in the compendium as well as the US Surgeon General's call to action. I agree. I like the way you put it, right? It's a stake in the ground. It's for us to look back and say, hey, this is what we said we should be doing in 2020, and let's see where things are moving forwards. Is there anything else we have not talked about or covered that you would like to say? Fleetwood could go first.
Mm-hmm. Yeah, thanks. I would say as well that the activities frequently align with other national initiatives that we've seen. And so a lot of the interventions that are recommended are included in national initiatives such as Target BP, the American Medical Association, American Heart Association collaboration, or the Million Hearts Initiative, the CDC and CMS collaboration. This prioritization of hypertension control is common across these, and the recommendations are drawing from a lot of the same evidence there as well. But I would also say, I think that the underpinning, if you look at the call to action, we have one main slide that we frequently reference. To me, as I get a bit older, it's harder to capture a lot of different things across a lot of different presentations. And so for me, I really liked having the call to action in one simple graphic, showing the goals, showing the strategies, but also underpinning the promotion of health equity. And I think that progress seen in hypertension control can be a great example of the promotion of health equity across populations. We know certain populations are really overburdened with this condition, such as African Americans, and have poor outcomes over time, earlier disease state many times as well. And so interventions that are implemented within hypertension control within communities can overall promote hypertension control, which in itself is extremely positive because it's one of the primary risk factors, of course, for cardiovascular disease. But also, I think it can be seen as an avenue for the larger promotion of health equity in the population as well. So investments that we have in hypertension control in healthcare settings can be replicated across other disease conditions, such as diabetes and others, which I know you know well, especially. And so I think that the call to action can be used in that manner for the overall promotion of health equity specifically.
Indeed, absolutely. Well said. What about you, Paul? Any final thoughts?
Yeah, so, Fleetwood said things so eloquently. The only thing, I would add would be there's, several, great points made throughout the issue. The NIH and the CDC in the article in the compendium talks about, there's a table that shows best practices and promising options for overcoming barriers to hypertension control. And going back to something Fleetwood, stated, having this one table that summarizes such important information, 7 items that we should be thinking about when working to improve blood pressure control, care coordination, team-based care, methods for implementing self-measured blood pressure monitoring, etc. And I think, in closing, it's not something that any one person can do, but as the Surgeon General says in the end of the report, together we've got this.
We've got this. Fantastic ending to this conversation. Thanks, Paul and Fleetwood. So the entire compendium can be checked out in the March 2022 issue of the American Journal of Hypertension. In addition, you can view the actual Surgeon General's call at cdc.gov/hypertension.
Blood pressure.
Yes, at blood pressure control. Sorry, cdc.gov. cdc.gov/blood pressure, and we'll have the links in the notes below the YouTube our video recording. Thanks again for joining this first issue of the Conversations for the American Journal of Hypertension.
Thank you.
Thank you.